Welcome back to our fourth session discussing cardiac surgical resuscitation. I'm here again with my expert panel, Tara Bartley, John Whitlock, and Christina Segura. We are delighted to be here today to talk about bleeding and tamponade and how you manage that in your critical care units. These scenarios both fall under that PEA algorithm. And again, really with the PEA algorithm, what you really want to do is just make sure you're not missing an opportunity for a shockable rhythm. So for example, if your pacemaker is on, we advocate that you pause the pacemaker to remove the spike so you can get a clear look at the rhythm, make sure you're not missing a fibrillation. And some centers, myself included, also suggest at some point just double check it in a second lead, again, to make sure you're not missing that shockable rhythm. Focusing on bleeding and tamponade, I'm going to start with you first, John. Last week, I asked if your nurses would strip chest tubes if they suspected tamponade, and I believe you replied yes, as did all of us. And so could you please describe, how your nurses normally manage chest tubes, what steps you teach to maintain patency of tubes, and anything in particular that they might do if they were fearful that the tubes were clogging?
Thanks again for having me, Jill. Back for the fourth time, so I must not have scared you off. Anyways, I the topic of chest tube stripping is controversial, I think, in most cardiac surgery programs because we do teach that stripping is not recommended, and yet many of the surgeons prefer to strip, and the nurses see them doing that and tend to follow suit. Some of them. I do find that there is some generational change that I'm observing now where some of the newer nurses are less likely to go ahead and strip chest tubes, whereas some of my more experienced nurses will. We do formally teach that stripping is not recommended. That comes mostly from thoracic surgery. I will say that you have mentioned some of the chest tube systems that actually have some stripping capability or a clearing capability through a loop that's part of the tube system. And we do not use that here, but I
Mhm.
do enjoy the thought of the nurses having something to do in lieu of stripping.
Thank you. Yeah, and it's the what John's referring to is the clearance technology. I think Pluriflow is the proprietary name for it, and this did come out in the ERAS guidelines recently as a recommendation. So I appreciate that you mentioned it, and I'll see with our next provider, Christina. How are your nurses managing chest tubes, and do you use any of those clearance chest tubes that are now marketable?
I mean, I never heard of that device before. So at least in our hospital, we don't use it, but I think we kind of speak before with Tara, and then it must be an UK thing that we don't use. Our nurses, I mean, everyone tends to, that's the first thing. As soon as you go to ITU with a surgeon, with a nurse, they all tend to kind of, we used to call it in England milky. Yeah. And we had a device that was like two rollers, and you used to roll it and roll it until all became like, no, we need to stop doing this. We need to stop doing this. But, every surgeon will come round to see a patient on ITU, will start kind of touching those drains. So I think it's a historical thing that everyone needs to do. It's like an instinct. When we're saying that when our nurses, they jump into anyone's chest, it's the instinct, and our nurses, they are still milking. But I think the problem is most of the time the clot is at the beginning of the top of the drain inside. So for more that you milk in, it's not going to come out. And when you do a reopening, you can see those drains that there is a full clot all along the line. So I don't see how you can do that from externally. If you've got a device that you can take that, fine. I haven't seen it, so I don't know how it works. But anything that you disconnect drains and put things in, and it's always you bring in new risk or high risk of infection. But again, I don't know how it works, so I can't really talk about this device because I don't know. But I think it's a historical thing. Everyone touched those drains, and everyone likes to see if it's more coming in, or even lift it up to see if it comes up. So
Marching up the chest tubes. Yeah, I've seen that plenty of times. Um, Tara, what are you doing? I mean, I think we're all kind of seeing the same thing, is that we teach our nurses to manipulate tubes gently, milking them. But when things are really deteriorating and your patient is in tamponade, then, basically we would do just about anything, including suck the clot out with a suction catheter if our surgeons told us to. So, Tara, what are you guys doing to maintain chest tube patency?
So I'm just going to take a step back and say, obviously, the CALS protocol is around the deteriorating patient prior to opening the chest. So in terms of looking to see whether bleeding is iatrogenic from something intraoperative, or whether in fact it's related to pharmacology, we're looking at what medication we've paused preoperatively. We're looking at monitoring the sort of the clotting cascade postoperatively. And it's quite funny what you just said there about marching up the tube, where you can actually see it bobbing with the heart rhythm, and you can actually feel how warm that blood is as well. It's a catch-22, isn't it? Milking is going to increase interthoracic pressure, negativity. It's going to, in theory, damage tissue. The other alternative way of looking at it is it will remove clots and it will avoid tamponade. And if you look at the discussions and the research out there, it is variable as to what you will see. So as Christina nicely explained, in the UK, we used to have historically these little clamps that you roll to pull. And there you have no way of judging how hard, you are actually performing. And also you have not really had that much insight into how friable the tissue is, the intraoperative processes that may or may not have been challenging. So again, proceed with caution. It's very much gone out of vogue across the UK for exactly the reasons that I have explained. But as you quite rightly say, if we end up in a situation where it's life or death, then obviously we will look to concretely make sure things are patent. But there's a fine line between just routinely doing an exercise because it feels intuitively right to one where there is a real rationale for an emergency intervention. And I would take us back round in a circle to how do we spot the deteriorating patient? How much is in the drains? What's the cardiac output doing? Is there signs of tamponade? Are the hemodynamics all leading in the wrong direction?
Thank you. I mean, I think you raised really a really key point here is when what we're taught to do under prophylactic circumstances and preventing the tubes from clotting is generally, much more benign. And I also am seeing the same things. I think very few people are stripping chest tubes routinely. They may milk them, but by and large, I think the key point that we're all making is monitor chest tube drainage, be alert for certainly the sudden cessation of chest tube output or clot formation that might signal the onset of tamponade, and to try and keep those tubes patent, and to alert your physicians or your allied health providers or your advanced practitioners if there's something wrong there. Thank you. I appreciate all of your feedback on that. And again, if anybody's interested, take a look at the new ERAS protocols that came out. Those are on the CTSNet website, and they'll give you some more information about that clearance technology if you're interested. Christina, back to you. So, clearly the key thing here is to recognize bleeding that warrants physician notification. And in my own experience, that varies from patient to patient and surgeon to surgeon. Do you have any sort of standing guidelines about when you call the surgeon? Is that included in your orders? Do you see that sort of variation? What is your cue that you would need to notify the surgeon that there are problems?
Yeah, I think that you have to take into consideration a lot of things. You have to know the patient, the troubles that you had in theater, if the patient was on any antiplatelet or anticoagulant, when it was stopped, if there's any risk that was continue, if it's an urgent, an emergency. So everything that you have to put into context and then all together, shake it, and then discuss it with your team, is it? Because yes, you sometimes, I mean, in theory, what we normally happens is, at least in our center, is the anesthetist who is on ITU. If he starts, I know Carl's has got it's not really a protocol, but he's got some kind of guidelines. If he trains for more than 400 mils an hour, it means severe. And we know those numbers, but those numbers doesn't mean anything unless you've got the whole story of the patient. What we tend to do is a tech that I think it's quite routinely in most places. You look for platelets, but I think a mapping of the tech is like a mapping platelets and mapping antiplatelets. So if the patient is being on any like ticagrelol or any of those medications, so then it gives you an idea where you're heading, if it's something coagulopathy or it's more like what we call proline, is it more surgery, more
Milk
surgeons
deficiency.
hands. So I think you need to put in context all this, and then is when you make a decision. Maybe you want to do a TOE while the patient is asleep. So I think you have to have, or at least from my experience, it's not just one thing. It's not like the patient has bled that amount of blood. It's just you have to have the whole context. I don't know what my other colleagues will say, but I think that's at least is what's how we work here.
So you said that you use TEG, the thromboelastogram, and your anesthesiologist runs that?
Yeah, so we used to have we used to do a ACT when the patient arrived ITU. I just had a conversation with the ITU girls, but a tech is a thing. I mean, sometimes we even use it before the surgery if someone is being on antiplatelet or dual antiplatelet, and then we can just assess if the patient is ready, or we can wait another day. So it just gives you an idea. Now you've got more tools than before, so you have to use them, isn't it? But yeah, definitely a tech is a thing to do first line, I would say.
Got it. Yeah, I think one of the key things we're trying to do is to rule out a coagulopathy and treat it before we take somebody back to the OR.
Exactly.
Tara, how about your program? Do you have any other, different criteria, and do you also use TEG or ROTEM?
Yes, so I would completely echo what Christina has said. It's very much surgeon dependent, but as a ballpark, different units will have different parameters, but they essentially fit with what is in the CALS protocol. So, if you are up to 200 mils an hour, then you are starting to look at what are the causes and what's going wrong. 400 is definitely, a cause for concern. I think you need to look at the pattern. Is it when you've rolled the patient? Is it a continuous? And you, as Christina says, you go right back to preoperatively. We in the UK will stop sort of our dual antiplatelets prior to surgery. For our acute patients, we will usually carry on with aspirin, but we will stop everything else. Clopidogrel is often the second drug of choice in dual antiplatelets. But interestingly, there is work out there that suggests that there is at least 30% of people that are non-responders to clopidogrel. So if you have an urgent case that you need to do with an in-house hospital patient, we will actually use ROTEM just to have a look to see in terms of clot formation and give us a bit of, rather than delay surgery, give us a little bit of information around what should our expectations be, how should we manage the potential or the actual bleeding intraoperatively. And likewise, it's interesting, isn't it? Because we've all been with the patient that's bleeding post-operatively, and it's in the evening and the surgeons are gone or heading home, and the whole anesthetic team and the theatre team aren't necessarily around or going to be around. And is it better to deal with this issue there and then, but you don't want to take people back to theatre unnecessarily? So I think the whole TEG, ROTEM, etc., is a very good device for working out, are you dealing with a proline-induced bleed, as we call it, or an underlying coagulopathy that you could look to reverse. And also it's important, isn't it, when you are, and we'll get onto this in the massive hemorrhage protocol, but when you are looking at putting products in, what are you doing? What products are you using? And what pharmacology are you using to support staving off bleeding, and also, further extending that to management of blood pressure. If you've got a high blood pressure, then obviously you are going to be supporting any bleeding, whereas, you don't want too low a blood pressure because you need to perfuse organs. So as Christina said, it's a real 360 considered approach, and better to be considered in a proactive way rather than a reactive way, I would suggest.
John, how about you? Have you got any other criteria that you might use or look at? And are you using TEG or ROTEM in your program?
No, as I'm listening to my colleagues answer the question, I'm struck with how interesting it is to be reminded that a lot of our practice is driven by our resources. And TAG is not something that my institution has invested a lot of energy into. And so the TAG machine that we have is available to us, but we consider it more of an extreme situations. It's not staffed 24/7, so it's not our first go-to. We tend to follow ACTs on a whole, but are leaning more towards the anti-10A assay now because it's more specific to heparin. Our anesthesiologists monitor heparin levels before the patient leaves the OR. Almost all of our patients receive TXA, and they do get protamine after they come off pump, and sometimes they'll get an additional dose of protamine here. That's a fine line, in thinking about what Tara and Christina say and looking at the whole picture, because we don't actually want to be creating clot by giving these drugs, but we also want to minimize the bleeding. So that is pretty much our patient by patient approach. There is out there in the hallway talks that constant number of 200 an hour as being kind of the cutoff point for going back to the OR, but it's soft.
Again, I really appreciate. I think this is one of the challenging algorithms. I've never seen a really tight protocol for bleeding. I think, it's very reactive to what you see, and, putting together the clinical picture, as you mentioned, what anticoagulants was the patient on before surgery? Was there any sort of, technical misadventure in the operating room? And where are their coags now? I'll never forget, we had a liver transplant patient that we were tuning up before she had her transplant. So she had an aortic valve procedure, and she was putting out over 400 an hour the first couple of hours. And she never went back to the OR. I mean, it was all coagulopathic, and we were able to, use our tests and correct factors and that sort of thing. So I think we're all really seeing that every patient is different, and that you really have to look at all of the tools at your disposal. But I heard permissive hypotension, and as like, don't let their pressure get too high, and also don't rewarm them too quickly, because then you will have a big tank to fill up with products that you may not have available. Thank you. So Tara, you mentioned massive transfusion protocol. Let's ask you about yours. What does your massive transfusion protocol entail? We have one. We can use it in the OR and labor and delivery in the ICU. I think those are the only places in our facility that use massive transfusion. What does yours look like?
Yeah, I think you hit the nail on the head there, Jill. I think we would hope that it's not something that we would need in cardiac surgery for the non-trauma cardiac surgical patient. So in the elective or the urgent valve and graft surgery and aortic surgery, it shouldn't be something that would be required unless, something catastrophic happens, particularly with the aorta, or there's there's an incident intraoperatively where perhaps something is damaged inadvertently or for whatever reason. On the CALS courses that I have been on one where they do look at the massive protocol transfusion side of things. And I think the key there is have you got a system in place? Have you got an activation that works with the key personnel and the infrastructure around that to deliver the products in the way that you need them early enough? So have you already preempted, as you say, have you got a benchmark liver function? Have you got cross matches available if necessary, and units there? And if you do need to activate it, have you got the machine to deliver it as rapidly as it needs to be, and somebody who knows how to set the machine up and somebody who knows how to deliver? Have you got the processes to get the units there in good time? And are you doing a 1-1-1 in terms of the blood, the platelets, the plasma side of things, so that you've got a balance? Because what you don't want to do is save someone's life and then end up with a DIC or a chest complication that you could have avoided. Obviously, you can't in a massive protocol transfusion side of things, but you might do 1-1-1, you might do 2-1-1, and so it's for your individual units to work out: have you got the human resources, the financial resources, the infrastructure, and all the educational side to follow a protocol when it's necessary? And I would argue that you would hope, unless there is a catastrophic event, that isn't something that we should be doing need with our patients, because we should be preempting it preoperatively, as I said, stopping drugs, making sure coagulopathy is as it should be, and then checking patients are stable prior to leaving theatres, and then picking up on the deteriorating patient in a timely fashion.
In a perfect world, I would never need a massive transfusion protocol. However, I have been very grateful for it numerous times in my career. John, what does your massive transfusion protocol look like? And is it part of your CSR courses?
We actually review the rapid blood infuser when we do our monthly mock open chest arrests. So people are familiar with how to load and use that piece of equipment. And we review it on the initial class, but we don't emphasize it, I would say. Our massive transfusion protocol is pretty much guided by two different pathways. If this is a patient, a trauma patient that needs massive transfusion, there's more blood clot factors included in their coolers. We get a cooler with generally 4 units of packed cells, 2 units of FFP, and alternating 1 unit of platelets. I would say that our biggest challenge in the United States with massive transfusion protocol is the safety steps that have been placed around blood transfusion in general are almost impossible to meet during a massive transfusion protocol. So we've worked very hard at streamlining how we document the checking the blood against the patient's armband and meeting all the needs that our regulatory agencies are looking for. That is honestly one of probably our biggest challenge, that and our documentation system.
Thank you. Oh, boy, I agree. We have a special form that we use just to sort of check all the boxes that, we've gone through those steps. But you're right, it's fairly onerous during a big bleed. Christina, do you have a massive transfusion protocol that looks something like that? And how do you guys use it?
So it's interesting because I think the theme is always you need to have whatever protocol it works for your unit. You need to discuss it with your teams and you need to find out what is best. And if it doesn't work, then change it. I think it's kind of the theme that every week we kind of go through, is it? So in our center, we used to have in our unit, intensive care unit, a fridge, and even in theaters with blood and, several things. But all this stopped and it was centralized. So then we have to create something. So then we created this hemorrhage protocol that you can activate it if you are in theater or in A&E or in ITU. So you just activate it. So if it's a reopening or a patient who is bleeding, you just activate it. And then with the packet, it comes 2 units of platelets, 2 units of red cells, and 2 units of FFP. So it kind of, that's kind of the first hint that you can use, and then if you need more, then you can go for other things. So we change things, and now we've got this protocol that you can activate. But of course, it's different if you are in A&E with a clamshell or you're in A&E with any trauma. Then you probably will need more than that, is it? But that's a kind of initial one, before you consider other things.
And I think
that's how it works.
Jill, just to, we haven't mentioned about fibrolysis in terms of tranexamic acid or products,
No.
in terms of medication as well. So whether there is a place for that in a patient that's, you know, putting out drain output more than it you know, is expected, or whether actually, you know, we should be actually just getting back in the chest and looking what's going on. Certainly when the patient starts to deteriorate, we should be not hesitating to go back to theatres and delaying or not opening the chest in a timely fashion, which is the, you know, the luxury, if you could argue that word, that we have within our patient cohort, rather than, you know, somebody who's had a trauma, or, you know, it's a maternity or something else in ED.
And that kind of go back to the previous question when we were talking about you need to have a look at your whole patient and the circumstances, because it's not the same someone in trauma, like you're saying, Tara, that it's bleeding and you just need volume and volume, to someone who is maybe bleeding just a tiny bit, but it's just tamponade. It's 2 different situations. So it will come to the previous question.
Yeah. I mean, I think it's great that we all have these. I mean, I didn't have a massive transfusion protocol 10 years ago. I think that's when we first probably started working on it. And the liver team was the first to get theirs in place, and we just saw how invaluable they were. And so we'll get 2 red cells, 2 FFP, and 1 platelet, and then we can keep those coming, you know, every 5 to 10 minutes. But again, the documentation piece of it was made simpler. And you mentioned tranexamic acid. I heard John mention tranexamic acid. That's something that is routinely used in our program. But I'd like to now ask all of you about additional factors. Factor 9, or PCC, prothrombin complex concentrate, is sometimes advocated either preventively or to treat bleeding. And then factor 7 is typically used more as a treatment. Beginning with John, are you seeing either of these factors used in your program at all, only in dire circumstances, or is that something that you don't really use very much?
Very, very rarely do we see either one of those, and it's more often than not because we've identified a deficiency in one of those factors. We do have one surgeon that has a lower threshold for using K-Centra,
Okay.
but that's it.
Yeah, I would say the same. We've got one that likes to use it fairly prophylactically in a large number of patients, but not all. How about you, Christina? Do you see either factor 7 or factor 9 used at your center?
So we'll use, as Tara said, we'll use thrombin, we'll use off bypass, we'll use factor 7 is like gold. So it's the last
Very
resource,
expensive.
and you
Yeah.
have to talk to probably to the hematology on call to get this.
Yes.
And fight for it. So there is other products. We use Betterplex. So there is all the artificial ones that you can use. So until we reach to the golden one. So factor 7, I've never seen factor 9, but factor 7, it will be the gold.
Got it. Tara, how about you?
So yeah, I mean, I think you know, we're all aware, aren't we, of the pathophysiology of bypass and what it does. And so, you know, intraoperatively, what we are hoping is that the surgical and the anaesthetic team, you know, have got a dry bed when they leave, and that they have, you know, controlled bleeding. And, you know, in terms of trying to reuse patients' own blood as a transfusion rather than artificial products is a good way of doing it, because obviously it works more effectively and it saves on all the sort of the human and financial resources. And same as Christina says, very plex, you know, transaminase acid, etc. But ultimately, I think the go-to is for us is to do a ROTEM and look to see if it's a proline or a coagulation unit. And if it needs platelets and FFP, then that's what's required, then that's what should be given. But it should be given, you know, in a non-reactionary way, in a way that actually says, you know, well, we can see from the clot formation on the ROTEM what is required here. And again, back to what we said before, you know, preventing that in the sense of working out if there's any other pathology in the liver or any other, you know, presenting history with the patient, such as, you know, a factor deficiency prior to that, getting your benchmark liver tests and making sure that you have a, you know, a dry patient when they come out to the best of the ability of the surgical team.
Thank you. I have some experience with both of these medications, and factor 9, I'm surprised a lot of anesthesiologists in the United States are really saying that this is going to replace plasma. I'm just not seeing it. I am not seeing it. It, you know, is reported in the literature as a real plasma sparing intervention. And again, we've got one surgeon that likes to use it, but I haven't seen it really make mainstream yet. Factor 7, on the other hand, I just wanted to mention when it first came out, there was a lot of concern that it was procoagulant, that it would close off grafts. And I think most surgeons were very loath to use it. We've since learned that it's not that procoagulant, that it won't, you know, precipitate graft closure. It is a very effective hemostatic agent, but it's super expensive. And so we also have to, you know, get dispensation from God and the chief of pharmacy, same person, in order to be able to, you know, use this medication. So again, I think what my thought about this, as much as I've always thought there should be a universal algorithm for bleeding, there can't be. I mean, because of all the things that we've talked about today, the surgeon differences, the patient differences, this particular patient, you think it's a platelet problem, but your ROTEM says that it's not. So, you know, I think it's really critical that we assess and treat based on all the information. And that's exactly what CSR CALS teaches us, to look for signs of a deteriorating patient, to gather all the information we can, to treat that problem and investigate it further, and then to take the right steps based on the data that we have. And if we're not as adept at it as we hope, we may get a tamponade. And so we haven't really focused on that a lot today. Our session next time will focus on LV dysfunction. And I think the differentiation between a tamponade and an LV dysfunction patient is something we will speak to next week. So for now, I'm going to close with your last question, again, taking us towards tamponade. And I'll begin with Christina. Who is the most likely person or category of people that is going to reopen a chest in your unit at 2 o'clock in the morning?
I think it will be our registrar, junior doctor, that is surgical, because we've got them here all the time. But it could be an SCCP, which is an advanced clinical care practitioner, which is a nurse. So
Like
it
you.
will be one of the other.
Okay. So you have both advanced care providers, nursing providers, and you have
ITU.
surgical trainees.
Yes.
It could be either of those.
Yes.
Got it. John, what happened in your unit?
Oh, we're lucky to have a cardiac surgery fellow in-house at all times, and he's supported by, or she, by the intensivist, intensivist that covers the ICUs. And we also have a layer of advanced practice providers that can assist.
Fabulous. Tara?
So devil's advocate here a little bit, the best person who's there to do it in a timely fashion, who is clinically competent.
There you go.
In centres across the UK, it depends if you have a resident or a non-resident doctor, and I've experienced both. And at 2 in the morning, it will be whoever gets there first. And in terms of the advanced provider, as an ACP, so we're called now not ANPs because we're not all nurses by professional background. So we can have, you know, other health professionals, paramedics, physios, all trained for advanced practice and working collegiately in a team where they're, you know, they're all doing the same role. They would open the chest. And I think we've always said in CALS that it is up to the unit to decide that the provision is there and to make sure that you're in under 5 minutes with someone who is up to date and clinically competent to be able to do it. And in the units where there is not where it is just a surgeon position to do, then what they have found is anecdotally it has reduced time to opening because of the way the CALS are set up. Then everybody's in their role and everything's addressed prior to the person who is going to open the chest arriving on the unit. However, if you have an ACP and it is part of your governance, then there is no problem for them to open it. You then find you need to work out what surgical intervention is needed and what holding is in place as to how you progress from there. That wasn't a one-word answer, was it?
That's okay. But, you know, sometimes I'm asking questions that aren't. And I would just close by saying at our center, we're a center that requires our surgeons to be there. We do not have trainees or others at night. We have some of our intensivists that have been there a long time and participated in opening enough that they're very good and skilled at it. The good news is our surgeon on call is 10 minutes away, but that's 10 minutes. And so that means that we need to be very good at recognizing signs of distress and communicating that by calling the physician, not with a laundry list of hemodynamic changes, but one word or 3. The patient is in tamponade. Come now. So I think there's no perfect system, but we'll get into next week a little bit more about that emergent intervention and how we manage the sickest of the sick, the patient that's either in tamponade or acute LV dysfunction postoperatively. So I'll go ahead and close here. Once again, thank you, Christina, John, and Tara, for being the fabulous experts that you are. I hope that our audience has found this informational. We'll have one more session in 2 weeks, and that will be discussing LV dysfunction, and we look forward to having you join us then. Thank you so much. Take care.
Thanks.
Thank you.